Have you ever felt completely overwhelmed trying to understand a complex health topic like asthma?
Oh, definitely.
You pull up a dozen articles and suddenly you're just drowning in medical jargon, maybe conflicting information.
It's like trying to drink from a fire hose.
Exactly. Well, you're absolutely not alone in that feeling. Welcome to the Deep Dive. This is where we take your stack of sources, your articles, research, notes, and we extract the most important nuggets of knowledge. We give you that shortcut to being truly well-informed. Today, we're plunging into the fascinating world of asthma. We're drawing insights from a really comprehensive set of medical summaries and clinical guidelines.
Yeah, some solid material here.
Our mission, to give you a clear, concise, and honestly incredibly insightful understanding of asthma. Everything from its evolving definition right through to its surprisingly personalized management.
It's a big topic, but we'll break it down.
Whether you're a patient, a caregiver, or just someone, endlessly curious about how our bodies work, this deep dive will equip you. You'll get the clarity to understand what asthma truly is, how it's diagnosed, and the most modern approaches to managing it.
The goal is you'll walk away not just informed, but genuinely powerfully well-informed.
Okay, let's unpack this. So let's start with a really foundational shift in how we understand asthma. For a long time, it was often thought of as like one singular condition, right? Affecting everyone the same way.
That was the old thinking, yeah.
But what the latest research shows and what our sources really highlight is that it's actually a heterogeneous disease with variable inflammatory phenotypes.
Wow, okay, that's a mouthful.
It is a bit jargon heavy, isn't it?
But it sounds like we're moving beyond a one-size-fits-all idea.
That's exactly it. And that's a crucial observation. It's where the deeper understanding truly began to emerge. The focus has profoundly shifted.
Shifted how? From just thinking about bronchospasm, the immediate tightening of airways, to understanding that inflammation plays an absolutely critical role in its pathogenesis.
Ah, okay, so it's not just about the squeeze.
Right. It's about the underlying fire, the inflammation happening in the airways.
And the material details this inflammatory core, right? It describes the traditional Th2 inflammation hypothesis. Talks about acute, subacute, and chronic phases. What does that chronic phase really mean for someone with asthma? Is that where the sort of long-term damage happens?
You've hit on a key point. In the acute phase, you see that immediate reaction, mast cells degranulate, histamine gets released, leading to those quick symptoms we recognize.
Like the wheezing and tightness.
Exactly. The subacute phase brings in more inflammatory cells a few hours later, but it's that persistent, ongoing, sometimes cyclic chronic inflammation, and then the body's repeated attempts at healing that can unfortunately lead to airway remodeling.
Remodeling, what does that look like?
Well, imagine repeated inflammation causing scar tissue, thickened airway walls, maybe an increase in mucus glands. This can result in persistent obstruction that doesn't always fully respond to therapy over time. It's like the airways get permanently changed.
Okay, that makes sense. But the singular hypothesis, this idea of one main pathway, it was challenged. Why? Why couldn't it explain everything we see?
Well, it just didn't fully explain all presentations of asthma. For instance, you have people who have non-atopic asthma.
Meaning no allergies.
Right? They don't have an identifiable allergic trigger, which challenges the idea that all asthma is driven by the same allergic inflammation. We also see, significant variability in how different patients respond to standard treatments.
Ah, so some people get better with standard inhalers, others don't really.
Exactly. Which made researchers realize that other inflammatory pathways had to be at play. It's like realizing there are many different ingredients that can cause a reaction, not just one.
So this led to identifying distinct inflammatory subtypes. We learn about eosinophilic, neutrophilic, posigranulocytic, wow, these are specific cell types, and mixed granulocytic asthma, often identified through induced sputum cytology. Sounds like really digging deep.
It is. And this is where the cutting-edge concept of endotyping comes in. This truly represents the future of asthma care.
Endotyping, how's that different from just looking at symptoms?
Well, instead of just looking at observable characteristics, what we call phenotyping, like symptoms or triggers, endotyping dives deeper. It defines disease subtypes by their distinct molecular mechanisms.
Okay, so like the underlying biological pathway.
Precisely. Think about it. Instead of just trying a drug hoping it works, we can potentially identify your specific asthma fingerprint. This is the path to personal asthma therapy, offering truly tailored treatments.
That sounds revolutionary.
It really is. For example, we now know that some adults have a distinct allergic asthma type. Others might have severe late-onset hypereosinophilic asthma. Knowing this means their treatment strategy will be entirely different. It's a real game changer for precision medicine.
That's fascinating. It's like moving from a general prescription for cough to understanding the exact biological reason for your cough. Okay, so we've unpacked this evolving understanding of what asthma truly is, moving from a single thing to a complex tapestry.
Yeah, a much more nuanced picture.
But once we have a clearer picture, the next crucial step is, well, putting on our detective hats and figuring out how to definitively diagnose it. And that, my friends, involves some fascinating detective work, combining patient stories with objective measurements.
Indeed. When diagnosing asthma, clinicians are really looking for three core features.
Okay, what are they?
First, episodic symptoms consistent with asthma, like wheezing or cough, combined with evidence of variable airflow obstruction, or what's called hyperresponsiveness. Second, clear evidence that this airflow obstruction is at least partially reversible. And third, crucially, ruling out other possible diagnoses.
Right, it's a process of elimination and confirmation.
Exactly.
Let's think about a patient. Let's call him Mr. Johnson. He comes in describing periodic wheezing, maybe a nagging cough at night. Sometimes it gets better after using his wife's rescue inhaler, or maybe just on its own.
Okay.
Now, while symptoms improving is a good sign for him, the clinical guidelines are really clear. Symptom improvement alone isn't enough for a definitive diagnosis. We need objective evidence of that reversible airflow obstruction. Why is that objective part so important?
It's because so many conditions can cause wheezing or cough. Objective evidence, usually from lung function tests like spirometry, confirms that the airways themselves are actually narrowing and then opening back up. It pings it down.
Makes sense. But the patient history is still vital, right?
Absolutely paramount. Clinicians will probe for key indicators: recurrent wheezing, persistent cough, shortness of breath, symptoms that get worse at night or are triggered by specific things like cold air, exercise, or allergens.
And they look for related conditions, too.
Yes, associated conditions like eczema, hay fever, or a family history of asthma or allergies, what we call adipiety, significantly increase the probability. It's all about connecting those dots in the patient's story.
And the social history section in the material we reviewed is particularly striking. It talks about workplace, triggers, chemicals, powders, home environment factors, HVAC systems, carpets, pets, even cockroaches and mold, plus tobacco use. This raises an important question. Why does social history matter so much in asthma? It seems like a really big focus.
That's a critical question. It's because certain populations, like African American and Hispanic Latinx patients in the U.S., unfortunately face a disproportionate burden of asthma morbidity, meaning worse outcomes, more hospital visits.
Why is that?
Well, it's tragically tied to inequitable social determinants of health. Lower socioeconomic status is often linked to housing conditions with more triggers, maybe less access to consistent care, which in turn leads to more asthma-related hospitalizations and generally worse control. These factors aren't just triggers, they reveal systemic disparities. It's a sobering reality we have to acknowledge.
Yeah, that's really important context. Now, while a thorough physical exam is important, the guidelines note that a normal physical exam doesn't rule out asthma, especially if it's intermittent.
Precisely. The symptoms can be very variable. You might catch someone on a good day when their lungs sound completely clear.
And you need to be aware of other conditions that can mimic asthma or even coexist with it.
Absolutely. The guidelines mention conditions like allergic bronchopulmonary aspergillosis, a specific type of lung inflammation called eosinophilic granulomatosis with polyangiitis, even vocal cord dysfunction where the vocal cords close inappropriately. This really underscores the need for thorough investigation to make sure you have the right diagnosis before starting treatment.
Okay, let's move on to spirometry. It's often called the lungs report card. It sounds like a super important test. What exactly does it measure?
It is fundamental. Spirometry measures two main things. First is the forced vital capacity, or FVC. That's the total amount of air you can forcibly exhale after taking the deepest possible breath. Think of it as your total usable lung volume.
Okay, the total volume.
And then there's the forced expiratory volume in 1 second, or FEV1. That's how much of that total air you can blast out in just that first second.
So how do these numbers tell us if there's an obstruction? How does this report card reveal a problem?
The critical sign is a reduced FEV1-FEC ratio. Imagine your FEC, your total lung capacity, is like a full glass of water. FEV1 is how much water you can pour out in just 1 second. If that ratio, how much you get out quickly compared to the total, is too low, it suggests there's a bottleneck somewhere.
Like a kink in the hose.
Exactly. There's an obstruction in your airways. We compare this ratio to what's considered the lower limit of normal, or LLN, for someone of your age, sex, and height, to confirm that obstruction objectively.
So it's not just about the FEV1 number itself, but the ratio.
Precisely. Consider a patient, let's call her Mrs. Eleanor. Her FVC might be a bit low, but if her FEV1 FVC ratio is normal, it might point towards a restrictive lung problem, not an obstructive one like asthma. It highlights why looking at that ratio is absolutely key.
And reversibility, that's the big differentiator for asthma compared to conditions like COPD, right? That's the big tell.
It's often the hallmark, yes. Demonstrating reversibility is crucial. This means we measure spirometry, give the patient an inhaled bronchodilator medication, a rescue inhaler, wait a bit, and measure again.
And what are you looking for?
A significant improvement. Specifically, an increase of more than 10% of the predicted value in either FEV1 or FVC after the bronchodilator. In asthma, that obstruction is typically reversible, meaning the airways open up significantly. In COPD, it generally isn't, or the improvement is much less pronounced.
But there's a critical nuance, as the guidelines point out. A lack of reversibility doesn't always rule out asthma.
That's extremely important. Especially in poorly controlled or long-standing asthma, the airways might be so inflamed or even remodeled, like we talked about earlier, that they don't show that immediate significant improvement with a single dose of bronchodilator.
Okay, so it's a strong clue, but not absolute proof either way.
Right. Also, it's vital to remember that normal spirometry results in an asymptomatic patient do not exclude asthma.
Why not?
If we connect this to the bigger picture, it really highlights asthma's episodic nature. Symptoms and obstruction can come and go. So a snapshot of normal lung function today doesn't mean asthma isn't present at other times or won't be triggered tomorrow. The lungs might look completely clear until a trigger arrives.
Spirometry can also give clues about restrictive lung disease, you mentioned. If the FVC itself is less than the LLN, that suggests a restrictive defect.
Correct, though you'd need a full lung volume test, measuring total lung capacity, TLC, to definitively confirm restriction. And sometimes you can even see combined obstructive and restrictive defects on spirometry. Our lungs are complex.
And then we have flow volume loops. These sound interesting, a visual aid.
Yeah, they are pretty neat. They graph airflow against lung volume during forced breathing. A normal loop has a characteristic shape, sort of like a smooth triangle on its side.
Okay.
In obstructive lung diseases like asthma or COPD, you often see a change in that shape. Specifically, a concave upward or scooped appearance on the expiratory limb, the part showing air flowing out. It's a visible sign of that bottleneck or airflow limitation.
Can it show other things too?
Definitely.
Mm-hmm.
For instance, in a patient we reviewed who had a history of tracheotomy, the flow volume loop showed a flattening on both the inspiratory and expiratory limbs. That's characteristic of a fixed upper airway obstruction. These loops can help differentiate between obstructions inside or outside the chest, or obstructions that are fixed versus variable. It's like getting a visual snapshot of the airway mechanics.
A crucial distinction the guidelines make is between asthma and COPD. They both involve obstruction, but how do lung function tests really help us tell them apart? Think about someone like Mr. Smith, maybe a longtime smoker, versus Mrs. Jones, who's had allergies since childhood.
It's a common clinical challenge. While obstruction, meaning that low FEV1 FVC ratio, is present in both, significant reversibility with a bronchodilator strongly favors asthma. COPD generally lacks that big FEV1 jump.
Okay, reversibility is key. Anything else?
Another important difference is the diffusing capacity, or DLCO. This measures how well gas, like oxygen, transfers from the air sacs into the blood. It's typically normal or even increased in asthma, possibly due to increased blood flow in the lungs during inflammation, but it's usually decreased in COPD, especially emphysema, because the delicate air sacs where gas exchange happens are often damaged or destroyed.
What about things like total lung capacity?
Total lung capacity, TLC, and residual volume, RV, the air left after exhaling fully can be similar or increased in both conditions, particularly if there's air trapping. So those measurements aren't usually as helpful for discriminating between asthma and COPD.
Beyond spirometry, other diagnostic tests can be helpful. One is monitoring the diurnal variation of peak expiratory flow, or PEF. What's that telling us?
PEF is the maximum speed you can blow air out. If a patient monitors it twice a day, maybe morning and evening, for a few weeks using a simple handheld meter, a pattern emerges. A greater than 10% variability between the highest and lowest readings over that period strongly suggests asthma. It shows that airway caliber is changing significantly throughout the day.
Okay, that makes sense. And then there's the methacholine challenge. When would you use that?
This is typically indicated when you strongly suspect asthma based on symptoms, but their baseline spirometry is normal, and maybe there's no significant PEF variation.
How does it work?
Methacholine is a substance that, when inhaled, causes airway smooth muscle to constrict slightly in susceptible people. In the test, the patient inhales increasing doses, and we measure their FEV1 after each dose. A drop of 20% or more in FEV1 indicates airway hyperresponsiveness, a key feature of asthma.
So a positive test means hyperresponsive airway.
Yes. It's a very sensitive test for asthma, meaning a negative test essentially excludes the diagnosis. If you don't react to methacholine, you almost certainly don't have asthma.
But is it specific? Does a positive test guarantee asthma?
Not necessarily. It's not perfectly specific. Other conditions like allergic rhinitis or even COPD sometimes can also lead to a positive result. And importantly, it's not recommended if the patient's starting FEV1 is already below about 65% predicted due to the risk of inducing severe bronchoconstriction. Safety first.
Okay, once asthma is diagnosed, we move to classifying its severity and assessing control. This is where it gets really interesting because the guidelines highlight a critical distinction. Severity is an initial assessment, right? Made preferably before long-term control or therapy begins.
Exactly. It tells us how serious the asthma is at the starting point.
But control is assessed at each visit after therapy starts. And it's control, not severity, that truly predicts future morbidity, future problems. That's a huge difference.
It is a vital point. The NAEPCCC guidelines for severity assessment combine several things. They look at current spirometry, but also a review of the past 2-4 weeks symptoms.
Like what kind of symptoms?
Things like how often someone is coughing, feeling short of breath, wheezing, how often they're waking up at night because of asthma, how much rescue inhaler, the SABA they're using, and if their daily activity is limited by their symptoms.
Okay.
They also look at the history of exacerbations flares requiring oral steroids in the past year.
Can you give an example?
Sure. Let's say a patient, Ms. Davis, has symptoms daily, uses her rescue inhaler maybe 4 days a week, and has 3 night awakenings a month. Based on those criteria, her asthma would be classified initially as moderate persistent.
And what about those exacerbations?
A really important detail. If someone has had more than one exacerbation requiring oral steroids in the past year, they're automatically considered to have at least persistent asthma, even if their day-to-day symptoms seem minimal between those flares. Those exacerbations signal significant underlying inflammation.
There's also a key difference mentioned between the NAPPCC and GINA guidelines on severity assessment itself.
Yes, there is a subtle but important difference. NAPPCC emphasizes assessing severity prior to starting control or therapy. It essentially sets the starting line for treatment intensity.
Oh, wait, initial assessment.
GINA, on the other hand, tends to assess severity more retrospectively based on the level of treatment, the step that's required to actually achieve and maintain good control.
So GINA looks back and says, okay, you needed step 4 treatment to get control, therefore you have severe asthma.
Pretty much. It's like measuring how far you ran to win the race, rather than just how fast you started. Both approaches have value, but it's good to know the distinction.
Using the NIPPCC initial classification then, how would some examples look?
Okay, so a patient like Mrs. Eleanor, with symptoms maybe twice a week or less, normal lung function between episodes, she'd be classified as intermittent.
Got it.
A patient like Mr. David, maybe wheezing 3 times a week, waking up 3 nights a month, using his rescue inhaler a few times a week, that fits mild persistent.
Right.
And Mrs. Peterson, with symptoms throughout the day, severe activity limitation, using her rescue inhaler daily, plus maybe a recent ICU admission for asthma that's clearly severe persistent. These initial classifications really guide the starting treatment approach, the initial step.
Okay, that makes sense. So once someone is on therapy, assessing asthma control becomes the main focus at every visit.
Absolutely. The guidelines categorize control into 3 levels: well-controlled, not well-controlled, or very poorly controlled. Sometimes just poorly controlled.
And how is control judged?
It involves looking at 2 key domains. First is current impairment. This includes those day-to-day things: symptoms, rescue SABA use, night awakenings, activity limitation. How is the asthma affecting you right now?
Okay, current impact. What's the second domain?
The second is future risk. This primarily looks at the risk of exacerbations, How many flares needing oral corticosteroids have they had recently? It also considers potential medication side effects.
So it's both how you feel now and what your risk is down the road.
Exactly. And what stands out here is a really practical tip, almost a rule of thumb for patients, is that a well-controlled asthmatic should rarely need to use their rescue inhaler for symptom relief.
How rarely?
The guidelines generally say less than twice a week. If you're reaching for that blue inhaler more often than that, your underlying asthma control likely isn't adequate, and your treatment probably needs adjustment.
That's a clear benchmark. Can you give an example of assessing control?
Sure. Take a patient, Mr. Thomas. He might tell you he feels fine, denies any activity limitation, maybe uses his rescue inhaler only twice a week. Seems okay on the impairment side. But if he's had 2 exacerbations requiring oral steroids in the past year, his asthma is still considered not well controlled because of that significant future risk domain, even if he feels okay day to day.
Right, those flares are a big red flag.
Absolutely. And you see this across the board. A patient like Mr. Green with daily coughing and wheezing, using his rescue inhaler constantly, clearly poorly controlled. While Mrs. White, maybe minimal current symptoms, but 2 oral steroid courses last year, she's not well controlled due to that risk domain.
What about side effects?
Good point. Mr. Stevens might be well controlled symptom-wise, hardly any flares, but he's getting frequent oral thrush from his inhaled corticosteroid. That side effect impacts his overall control and needs to be addressed, maybe by adjusting technique or dose.
And the level of control dictates the next steps in treatment.
Precisely. If it's not well controlled, you typically step up therapy 1 or sometimes 2 steps. If it's poorly controlled, definitely step up. If it's been well controlled for a while, you might consider stepping down carefully.
All right, now that we know how to classify and assess asthma, let's talk about managing it. The overall goal is so important. Achieve and maintain symptom control with the least amount of medication and the minimum side effects.
That's the balancing act, absolutely.
The guidelines, both NAEPCC and GINA, offer these stepwise approaches, often involving 6 or 5 steps, to achieve this balance.
Yes, they provide a structured framework for escalating or de-escalating therapy based on control.
Across both sets of guidelines, some general management principles seem to hold true.
Definitely. Quick relief medications, usually a short-acting beta agonist or SABA, should be prescribed for all patients for immediate rescue from symptoms.
Okay, everyone needs a reliever.
And as we just discussed, if a patient is using that SABA more than 2 days a week for symptom relief, not counting preventative use before exercise, it's a clear signal that their long-term control is inadequate.
What about flares?
A short course of oral steroids might be needed for managing moderate to severe exacerbations or for patients whose asthma is very poorly controlled while getting things back on track.
And how quickly should you follow up after changing treatment?
After initiating or adjusting therapy, patients should generally be reevaluated in about 2 to 6 weeks to see how they're responding and check for side effects.
And crucially, before just automatically stepping up therapy if someone isn't controlled.
Yes. Before stepping up, clinicians should always reassess a few key things. Adherence, are they actually taking the medication as prescribed? Inhaler technique, are they using their device correctly? Environmental control, are there triggers at home or work that aren't being managed? And comorbid conditions is something else like reflux or sinusitis flaring up their asthma. Sometimes addressing these issues is more effective than just adding more medicine.
That's so important. Okay, once control is achieved, how do we maintain it? Can we ever just stop medications or reduce them?
You should only consider stepping down therapy after good control has been achieved and maintained for at least 3 months. Asthma can be variable.
And how should that step down happen?
These reductions in medication should always be gradual and closely monitored. Asthma deterioration can sometimes be sudden, so you need to be cautious. Even with well-controlled asthma, regular follow-up evaluations, at least every 6 months, are recommended.
What about lung function tests long-term?
Spirometry is recommended not only initially and after achieving control, but then periodically, maybe every 1 to 2 years for most patients, as a kind of objective check-in on their lung function, even if they feel well.
And at every visit, it's about the whole picture.
Absolutely. Every visit should include reviewing patient education, checking adherence again, asking about side effects, reviewing environmental control measures, and managing any comorbid conditions. It's a holistic, ongoing process, not just a prescription refill.
Okay, let's delve into the asthma toolkit, the pharmacotherapy. For long-term control, inhaled corticosteroids, or ICS, are consistently highlighted as the most effective therapy. They really are the foundation, aren't they?
They absolutely are for most patients with persistent asthma. They work directly in the airways to reduce the underlying inflammation. They quiet down those overactive immune cells like eosinophils and reduce the production of inflammatory mediators. They treat the root cause in many types of asthma.
But they can have side effects.
They can, particularly local side effects.
Yeah.
Things like oral candidiasis, that's a yeast infection, or thrush in the mouth dysphonia, which is hoarseness, and sometimes cough can occur.
How can patients minimize those?
Using a spacer device with metered dose inhalers helps deliver the medicine to the lungs instead of the mouth and throat. And, crucially, rinsing the mouth with water and spitting after each use can significantly help prevent thrush and hoarseness.
Good tips. Next up are long-acting beta-2 agonists, or LABAs, like salmeterol and formoterol.
Yeah.
How do they work?
These work by relaxing the smooth muscle that wraps around the airways, helping to open them up and keep them open for a longer period, usually 12 hours or more.
I remember there used to be a big warning, a black box warning, about using LABAs alone in asthma. Has that changed?
That's a crucial update. The boxed warning regarding increased risk of severe exacerbations or asthma-related death with LABA use has actually been removed when LABAs are combined with an ICS in the same inhaler. Large safety studies confirm that when these medications are used together as prescribed, there wasn't a significant difference in serious adverse events compared to using the ICS alone.
Okay, so combination ICS-LABA inhalers are considered safe and effective.
Yes. However, LABA monotherapy, meaning using a LABA by itself without an accompanying ICS, is still absolutely contraindicated, still prohibited in asthma patients.
Why is that still prohibited?
Because using a LABA alone can mask worsening inflammation. It makes you feel better by opening the airways, but it doesn't treat the underlying fire. This can lead to a false sense of security and potentially delay appropriate treatment or lead to worse outcomes if a severe flare occurs. You must have the anti-inflammatory effect of the ICS.
Got it. Okay, another option in the toolkit, leukotriene modifiers like montelukast. The guidelines say they're an effective alternative, maybe especially for certain patients.
They can be, yes.
Yeah.
They work by blocking leukotrienes, which are another type of inflammatory chemical involved in asthma. They can be particularly useful as an alternative or add-on therapy, especially for patients who also have allergic rhinitis, or perhaps aspirin-exacerbated respiratory disease.
But there's an important warning with montelukast, right?
Yes, very important. Montelukast carries a boxed warning from the FDA regarding serious neuropsychiatric events, mental health side effects. These can include things like agitation, aggression, depression, sleep disturbances, and even suicidal thoughts or actions.
Wow, that's serious.
It is. This risk absolutely must be discussed with patients before starting the medication, so they and their families are aware and can report any changes in mood or behavior immediately. It's still a useful drug for some, but that risk needs careful consideration and monitoring. For example, if a patient like Mrs. Kelly was refusing a LABA or maybe higher dose ICS due to concerns, montelukast could be a viable alternative, provided she was fully counseled about these potential side effects.
Okay, so clear communication is key there. Now, there have been some really significant shifts in controller medication algorithms recently, particularly highlighted by the GINA guidelines. Tell us about the as-needed low-dose ICS formoterol strategy.
This is a huge shift, particularly in the approach to mild asthma, step 1 and 2. GINA now strongly recommends using a combination inhaler containing low-dose ICS plus formoterol, taken only as needed for symptom relief instead of just using a SABA reliever alone.
Why formoterol specifically?
Formoterol is unique among LABAs because it has both a fast onset of action, similar to a SABA rescue inhaler, and a long duration of action like a controller. So every time a patient with mild asthma uses it for relief, they're also getting a dose of the anti-inflammatory ICS.
So it ensures they get the inflammation treatment whenever they have symptoms.
Exactly. It addresses the underlying issue, even with intermittent use, and studies show this approach significantly reduces the risk of severe exacerbations compared to using a SABA alone for relief in mild asthma. The NAP-PCC guidelines are a bit more conservative here, still allowing SABA alone in step 1. But this GINA shift is really changing practice globally.
And related to this is MART, single maintenance and reliever therapy.
Yes. MART utilizes that same principle, but for moderate to severe asthma, steps 3, 4, and sometimes 5. Patients use an ICS formoterol combination inhaler for both their daily scheduled maintenance dose and as their reliever inhaler whenever they have symptoms.
So one inhaler does both jobs.
Correct. It simplifies therapy, just one device to carry and learn to use. And again, it ensures that whenever symptoms flare and they reach for the reliever, they're getting an extra dose of both the bronchodilator or Moverol and the anti-inflammatory ICS. This has been shown to be very effective in reducing exacerbations and the need for oral corticosteroids compared to traditional approaches with a separate SABA reliever. Both NEPTC and GINA now incorporate MART strategies.
That sounds like a much more integrated approach. Beyond these core therapies, other controllers are sometimes used.
Yes. Theophylline is an older oral medication. It has some bronchodilator and anti-inflammatory effects, but it has a narrow therapeutic window, meaning the dose needs to be just right, requires blood level monitoring, and has potential side effects and drug interactions. So it's generally reserved as an add-on therapy in difficult cases.
Okay.
And long-acting muscarinic antagonists, or LAMAs, like tiotropium, are another class of long-acting bronchodilators. They work differently from LABAs. They're often added on in step 4 or 5 for patients still uncontrolled on ICS-LABA therapy, or sometimes used if a patient can't tolerate a LABA.
Right. And then we reach the really exciting frontier for severe asthma. Immunotherapy, specifically biologics, these sound like a big deal.
They absolutely are. These are newer injectable treatments specifically for patients with severe asthma that isn't controlled despite high doses of standard therapies like ICS-LABA. They are truly groundbreaking because they act like precision-guided missiles.
Oh, needed missiles. How so?
Instead of broad-spectrum approaches like corticosteroids, biologics target very specific molecules or cells involved in the inflammatory pathways driving certain types of severe asthma. It's personalized medicine in action.
Can you give some examples?
Sure. For patients with severe allergic asthma driven by IgE antibodies, there's omalizumab, which blocks IgE. For patients with severe eosinophilic asthma, meaning high levels of eosinophils are driving the inflammation, we have several options like mepolizumab, reslizumab, and benralizumab, which target a key signaling molecule called IL-5 or its receptor, reducing eosinophil levels.
Okay, different targets for different underlying mechanisms.
Exactly. There's also dupilumab, which blocks signaling through 2 other inflammatory pathways, IL-4 and IL-13, and is effective in eosinophilic asthma, but also in patients dependent on oral corticosteroids. And the newest one, tezepelumab, works even further upstream by blocking TSLP, a molecule released early in the inflammatory cascade. This gives it broader activity across different types of severe asthma, even those without high eosinophils or allergy markers.
That's amazing. It sounds like we're really starting to dissect the different subtypes and target them specifically. This must be where biomarkers become really important.
Critically important. To choose the right biologic, we need to understand the patient's specific endotype. So tests like measuring serum IgE levels for allergic asthma, checking the eosinophil count in a complete blood count, CBC, and measuring fractional exhaled nitric oxide, or FeNO, which is a marker of eosinophilic airway inflammation and predicts responsiveness to corticosteroids, are increasingly used to guide therapy selection. They help pinpoint the driving mechanism.
Fascinating. What about emerging or maybe controversial therapies? Macrolides were mentioned.
Yes, macrolide antibiotics, like azithromycin, taken long-term at low doses, have shown some anti-inflammatory effects beyond their antibacterial action. Some studies suggest they might reduce exacerbations in certain asthma patients, perhaps those with more neutrophilic inflammation. However, there are significant concerns about promoting antimicrobial resistance with widespread long-term use. So they're generally reserved for very specific situations under specialist care, not routine practice.
Okay, caution needed there. And bronchial thermoplasty, what is that?
Bronchial thermoplasty, or BT, is a procedure done via bronchoscopy where controlled radiofrequency heat is applied to the airway walls. The goal is to reduce the amount of excess airway smooth muscle, which is thought to contribute to bronchoconstriction.
Does it work? Is it recommended?
Some studies showed modest improvements in quality of life and reduced exacerbations. However, the benefits appear relatively small compared to the risks, costs, and the effectiveness of newer biologic therapies. The NAEPCC guidelines specifically state that they do not recommend BT for routine care due to this unfavorable benefit-to-risk ratio at present. Maybe its role will become clearer in the future for very select patients, but not mainstream now.
Good to know. And just to round out the medications, quick relief. We have the SABAs, the traditional rescue inhalers like albuterol.
Yes, for immediate symptom relief. Though, as we discussed with the rise of ICS formoterol reliever strategies, especially in GINA, the reliance on SABA-only relief is decreasing for many patients.
And oral steroids for exacerbation.
Yes, short bursts, like prednisone, are crucial for managing moderate to severe flares to quickly reduce inflammation.
And ipratropium bromide.
That's a short-acting anticholinergic. It's sometimes added to SABA treatments, usually via nebulizer, in the emergency department setting for moderate to severe exacerbations. It provides some additional bronchodilation through a different mechanism.
Okay. It's vital to remember, though, that asthma management goes way beyond just medication. The guidelines consistently reiterate the importance of a holistic approach.
Absolutely. Patient education, addressing environmental factors, and managing comorbid conditions should be integral parts of the discussion at every visit.
Right.
It's not just about prescribing an inhaler and sending them out the door.
So environmental control, allergens, and irritants. What's the key message there?
The evidence strongly suggests that a comprehensive and multifaceted approach to avoidance is needed if triggers are identified. Single interventions, like just getting rid of the carpet or only using mattress covers, are often ineffective on their own. You need to tackle multiple triggers simultaneously if possible: dust mites, pets, mold, etc.
And what about outdoor triggers?
Outdoor air pollution is a huge issue. Pollutants like particulate matter, PM10, PM2.5, and ozone are clearly linked to asthma exacerbations, and even potentially the development of new-onset asthma, especially in children. Climate change is also implicated here, affecting pollen seasons and air quality.
So what can patients do?
Education is key. Patients should be encouraged to be aware of local air quality indexes, often available online or through weather apps, and advised to limit strenuous outdoor activities on days when air quality is poor.
Good advice. And comorbid conditions, they can significantly worsen asthma, right?
Definitely. The guidelines list common culprits: gastroesophageal reflux disease, GERD, obesity, chronic rhinosinusitis, obstructive sleep apnea, and even psychological factors like stress and anxiety. All of these can impact asthma control.
How does obesity affect asthma, for example?
Obesity makes asthma harder to control. It can alter lung mechanics, increase inflammation systemically, and make symptoms worse. We reviewed the case of a patient, Mr. Jones, who had severe uncontrolled asthma and morbid obesity. Importantly, studies have shown that significant weight reduction in obese asthmatics can lead to measurable improvements in lung function, quality of life, and fewer exacerbations. Addressing these comorbidities can be as impactful as adjusting medication sometimes.
Wow. It's a testament to how interconnected our body systems really are.
Absolutely.
The guidelines also point to some, let's call them, inconvenient truths in asthma care. Non-adherence is a big one.
It's a huge challenge. Studies suggest that up to 50% of patients with chronic illnesses, including asthma, may be non-adherent to their medication regimens.
50%? Why?
The reasons are complex. It can be unintentional, simply forgetting doses, confusion about the regimen, cost being a barrier. Or it can be intentional. Maybe they don't perceive a benefit or need, they're worried about side effects, or they dislike the medication or device. Empathy and non-judgmental discussion are crucial here to understand the barriers.
And the other inconvenient truth: improper inhaler technique.
Another major issue. It's estimated that an astonishing 70–80% of patients cannot demonstrate correct use of their inhaler device. If you don't use it right, the medicine doesn't get to the lungs where it's needed. This is a very common cause of seemingly uncontrolled symptoms.
So even if they take it, they might not be getting the benefit.
Exactly. And it's not about blaming the patient. Inhalers can be tricky. Metered dose inhalers, MDIs, the traditional puffer type, require good hand-breath coordination. Using a spacer device can make MDIs much easier and more effective for many people. Dry powder inhalers, DPIs, require less coordination, but need a strong, fast inhalation to draw the powder out effectively.
What's the solution?
Regular checks of inhaler technique by a healthcare provider, a doctor, nurse, pharmacist, or respiratory therapist are essential. Often, a quick demonstration and practice session can make all the difference in improving medication delivery and asthma control.
Okay, so adherence and technique are critical non-pharmacological factors. Now, what about when symptoms flare acutely? Managing exacerbations is crucial.
Yes. The guidelines define a flare or exacerbation as an acute or subacute worsening of symptoms, more dyspnea, cough, wheezing, chest tightness, accompanied by a decrease in lung function, usually measured by peak flow, dropping below 80% of the patient's personal best. It's when the alarm bells really go off.
And having a plan is key here.
The power of a written asthma action plan cannot be overstated. These plans should ideally be provided to all patients, but especially those with moderate to severe persistent disease or anyone with a history of severe exacerbations.
What does an action plan do?
It empowers self-management. It typically uses zones, green, yellow, red, based on symptoms and their peak flow readings, and gives specific instructions on what to do in each zone, when to use the reliever, when to potentially increase controller meds, if advised, and crucially, when to seek urgent medical attention. Take a patient like Mrs. Rodriguez. If her peak flow drops to 70%, yellow zone, Her action plan would likely tell her to take her rescue inhaler immediately, maybe repeat it, reassess her peak flow, and then call her doctor or follow specific instructions for adding medication like oral steroids if prescribed. It provides clear, immediate steps.
That sounds incredibly useful in a scary situation. It's also vital to identify patients at highest risk for really bad outcomes, even death from an exacerbation, right?
Absolutely crucial. Certain factors are known red flags. A history of previous near-fatal asthma, ICU admission, or intubation for asthma, frequent hospitalizations or emergency department visits in the past year, currently using or recently stopped using oral steroids, overuse of SABAs, like more than one canister a month, having a psychiatric history or psychosocial problems, or having difficulty perceiving the severity of their own airflow obstruction. These patients need extra vigilance and potentially more aggressive management.
When a flare happens, how is the decision made between managing it outpatient versus needing hospital admission?
It's based on clinical judgment, really, guided by several factors. Objective measures like peak flow readings, or FEV1, are important. The physical exam findings, oxygen saturation levels, respiratory rate, use of accessory muscles to breathe, ability to speak in full sentences, overall level of distress are critical. The patient's response to initial SABA treatment also guides this decision.
Are chest x-rays always needed?
No, chest x-rays are not routinely needed for typical asthma exacerbations unless you suspect a complication like pneumonia, pneumothorax, collapsed lung, or another diagnosis.
The guidelines walk through the response spectrum after that initial rescue inhaler dose. Can you explain the good, incomplete, poor response categories?
Sure. A good response typically means symptoms improve significantly and peak flow returns to greater than 80% of personal best. This indicates a mild exacerbation. Usually, they can continue their SABA as needed, and a short course of oral steroids often isn't necessary, though close follow-up is still wise.
Okay, that's the best case. What about incomplete?
An incomplete response means symptoms improve somewhat, but not fully, and peak flow is still in the range of about 50–80% of personal best. This suggests a moderate exacerbation. These patients should continue using their SABA frequently, and a course of systemic oral corticosteroids, or prednisone 40–60 milligrams daily for usually 3–10 days, is typically needed to get the inflammation under control. They also need prompt follow-up.
And the poor response?
A poor response is when symptoms persist or worsen despite initial SABA, and peak flow remains less than 50% of personal best. This indicates a severe exacerbation. These patients often have marked distress, difficulty speaking, maybe low oxygen levels. They require immediate emergency department referral for more aggressive treatment, potentially including continuous nebulized medications, IV steroids, oxygen, and close monitoring.
What if someone doesn't know their personal best peak flow? Can predicted values be used?
Yes, if the personal best isn't known, predicted values based on age, height, and sex can be used as a rough guide. There are also some critical absolute thresholds that generally warrant immediate ED referral. Regardless of personal best, for example, a peak flow consistently below 200 liters per minute for adult males, or below 150 pound/PM for adult females, especially if accompanied by significant respiratory distress. Safety is paramount.
Are there special considerations during exacerbations, like antibiotics?
Antibiotics are generally not indicated for routine asthma exacerbations. Asthma flares are typically driven by inflammation, often triggered by viruses or allergens, not usually primary bacterial infections. Antibiotics should only be used if there's clear clinical evidence of a concurrent bacterial infection, like pneumonia, fever, consolidation on X-ray, or bacterial sinusitis, purulent discharge, facial pain.
Okay. What about just doubling the dose of inhaled corticosteroids during a flare? Does that help?
Interestingly, studies have shown that simply doubling the regular maintenance dose of ICS during an established exacerbation is generally not effective in reducing its severity or the need for oral steroids.
Oh, really?
However, there is some evidence that quadrupling the ICS dose started very early at the first sign of worsening symptoms, like when entering the yellow zone of an action plan, and continued for about 7–14 days, may help prevent some exacerbations from progressing to the point where oral corticosteroids are needed. This needs to be part of a specific action plan strategy discussed with their doctor.
Good distinction. And over-the-counter remedies, like those Primatene mist inhalers.
The guidelines generally recommend against using over-the-counter asthma remedies like epinephrine inhalers. They provide only short-term relief, don't address the underlying inflammation, and crucially, their use can delay patients from seeking appropriate, more effective medical attention, which could be dangerous in a worsening flare.
Right. Stick to the prescribed plan. Okay, finally, let's briefly explore asthma in some special situations. First up, exercise-induced asthma, or more accurately, exercise-induced bronchoconstriction, EIB.
Yes, this is very common. Symptoms like cough, wheezing, shortness of breath, or chest tightness typically occur during or more often shortly after strenuous physical activity. They usually peak about 5–10 minutes after stopping exercise and then gradually resolve,
How is it diagnosed?
often and clinically based on the typical history. It can be confirmed objectively by demonstrating a drop in FEV1 or PEF of 50% or more after a standardized exercise challenge in the clinic or sometimes just after vigorous activity.
And how is it managed?
The most common approach is using a SABA, like albuterol, preventatively, about 15–30 minutes before exercise. This is effective for most people. If symptoms are very frequent or occur despite SABA pretreatment, then starting or optimizing a daily controller medication like an ICS or a leukotriene receptor antagonist, LTRA, like montelukast, is recommended. LTRAs can be particularly effective for EIB. A good warm-up period can also help.
Okay. What about cough variant asthma? Sounds like exactly what it is.
Pretty much. In this variant, chronic persistent cough is the primary or sometimes the only symptom of asthma. There might be no wheezing or shortness of breath. The cough is often dry and can be particularly troublesome at night.
That sounds like it could be easily missed or misdiagnosed.
It can be challenging, definitely. Many other conditions cause chronic cough, so those need to be ruled out first, like postnasal drip, GERD, effects of ACE inhibitor medications. Spirometry might be normal between cough episodes. Sometimes PEF monitoring showing variability or a positive methacholine challenge test can support the diagnosis. Ultimately, the definitive diagnosis often comes from seeing the cough respond clearly and significantly to a trial of asthma therapy, like inhaled corticosteroids.
So the treatment response confirms it. Now, asthma in pregnancy, this seems really important.
Critically important, the incidence of asthma appears to be increasing in pregnant women. And poorly controlled asthma during pregnancy is directly linked to significant adverse outcomes for both the mother and the baby.
Like what?
Risks include preeclampsia for the mother and for the fetus newborn, things like perinatal mortality, preterm birth, low birth weight, and complications requiring neonatal intensive care. The primary goal of asthma management during pregnancy is absolutely crucial. Maintain optimal lung function and oxygenation for the mother to ensure adequate oxygen supply to the developing fetus.
So it's vital to keep asthma well controlled. What about medication safety? Are asthma inhalers safe during pregnancy?
Yes, maintaining control is paramount, and most standard asthma medications are considered relatively safe and are certainly safer than having uncontrolled asthma. Butsine is often cited as the preferred inhaled corticosteroid during pregnancy because it has the most extensive safety data and is classified as FDA pregnancy category B. No evidence of risk in human studies. However, other ICS are also generally considered safe if they were controlling the patient's asthma well before pregnancy.
What about relievers and LABAs?
SABAs like albuterol are category C, but are essential for rescue therapy and considered safe. LABAs are also generally considered safe when used in combination with an ICS. Theophylline is sometimes used but requires monitoring. Leukotriene modifiers are often continued if they were essential for control pre-pregnancy after discussion of risks-benefits.
What should be avoided if possible?
Oral corticosteroids should be used cautiously and only when necessary for severe exacerbations, especially during the first trimester, as there might be a small increased risk of cleft palate, though the risk from uncontrolled severe asthma is generally considered greater. As we saw in a review case involving a pregnant patient, Mrs. Daniels, whose asthma wasn't controlled on a SABA alone, stepping up to inhaled bucinide was the appropriate and safe next step.
Good to know treatment can and should continue. Lastly, asthma and surgery. Are there specific risks?
Yes. Patients with asthma undergoing surgery, especially procedures involving general anesthesia and intubation, face increased risks of respiratory complications. These can include bronchoconstriction triggered by anesthesia or the breathing tube, hypoxemia, low oxygen levels, atelectasis, lung collapse, and respiratory infections.
So what's the key to minimizing these risks?
Preoperative optimization is essential. The goal is to have the patient's asthma as well controlled as possible before any elective surgery. This means ensuring minimal symptoms, optimal lung function, ideally FEV1 or PEF 80% of personal best or predicted, and reviewing their medication regimen.
What if their lung function isn't optimal before surgery?
If FEV1 or PEF is less than 80% shortly before elective surgery, a short course of systemic steroids, like prednisone, might be considered to reduce airway inflammation and minimize perioperative risks.
And what about patients already on long-term oral steroids?
Patients taking chronic systemic steroids will likely need stress dose steroids around the time of surgery to help their body cope with the physiological stress, as their own adrenal glands might not produce enough cortisol. The main takeaway is clear. Get the asthma under the best possible control before elective surgery to ensure the safest possible outcome.
Wow, okay. We have really journeyed through the complex, often surprising world of asthma today.
We certainly covered a lot of ground.
From its intricate inflammatory mechanisms and these cutting-edge diagnostics like endotyping,
Yeah, the move towards personalization is really exciting.
to the nuanced strategies for managing it in daily life and during those acute flares. And, importantly, not forgetting the crucial role of the environment, adherence, technique, and patient education.
It's clear that our understanding has truly progressed. It's not seen as just one single disease anymore, but this fascinating heterogeneous syndrome with many faces.
And that progression, as you said, is really paving the way for increasingly personalized treatments, moving beyond just treating symptoms to understanding the very unique biology of each individual's asthma.
That's the goal, precision medicine for asthma.
So what does this all mean for you listening in? Understanding asthma isn't just about memorizing facts. It's really about appreciating its multifaceted nature and these personalized approaches that are truly transforming lives. As you reflect on this deep dive, consider how far our understanding has come and the ongoing journey towards even more precise, individualized care. This knowledge isn't just for clinicians, it's empowering for anyone navigating the challenges of asthma, giving you the insights to advocate for yourself or your loved ones.
Knowledge is power, especially when managing a chronic condition.
Absolutely. So the question to leave you with is, based on this deeper understanding, what might you explore next about how our bodies work, or perhaps how healthcare is becoming increasingly tailored to the individual?